morning again, everyone, and welcome back to our conference. I hope you had time to stand up and stretch a little bit and grab some coffee or something else to drink and snack. We are beginning one of our 90-minute sessions, and we will take brief breaks in between each presentation. If you need closed captioning, you can access that below the video stream, and I will put a link to the evaluation for each of these sessions in the chat, and you can find it within each session as well. So just a couple reminders there. If you have questions for any of our presenters, please use the Q&A. And without further ado, I will get us started. I'm excited for our first presentation by Katie Polano, who is a physical therapist at Rehab Without Walls in Saco Bay Physical Therapy. She will be presenting this morning on accessible outdoor spaces and activities to promote health and well-being. So thank you for being with us, Katie. I will turn it over to you.
Thank you so much, Heather. I'm really excited to be here today. Hi, everyone. So as Heather said, I'm a physical therapist, been practicing for about 8 years. And last year I got my Master's of Public Health in Parks and Recreation because I'm really interested in the ways we can better collaborate as healthcare professionals, parks and recreation professionals, public health professionals to utilize the outdoors and nature to promote health, and how we can get people outside and have more equitable access to the outdoors. So thank you all for being here. I have no disclosures regarding commercial relationships and the contents of this presentation. So I'll be briefly talking about nature's health benefits and then how those benefits come about, the mechanisms of action. Then the inequitable distribution of nature, differing nature experiences, the inequitable access to nature, ways we can advocate, some clinical applications, community programming, and then some resources. So I just wanted to start with this quote by Nature for All. It's key messages for the healthcare sector. So basically, contact with nature is crucial for our physical, mental, social, and spiritual health. Indigenous people have known about these health and nature fundamental connections for tens of thousands of years. And now the conversation is starting to come back to this, and it's a really important message that I think we all need to integrate into our own professional and personal lives. So what are nature's health benefits? There are a lot. Some physical health benefits: nature reduces blood pressure. It can reduce the cortisol levels or the stress hormones in our body. It can reduce our resting heart rate. It can reduce diabetes prevalence and mortality. And it also supports immune function and physical activity levels. So I'm already starting to think as a clinician what I can do to leverage nature to promote health in my patients, just from knowing this. What about mental health? So we know that nature reduces stress. It reduces depression, anxiety, anger, frustration, and aggression. And it also improves our ability to recover from stress. So when people get stressed, they can recover more quickly from it. It improves happiness, our sense of well-being, our life satisfaction, our self-esteem. So mental health is such an important topic, and we really need to be leveraging nature to promote health. And cognitive health. We know studies have shown that nature improves working memory, cognitive flexibility, recovery from mental fatigue. It improves attention, creativity, learning, and academic performance. But how does nature improve health? There's a lot of theories and potential mechanisms for how nature improves health. There are a couple that I'll highlight here today. One is the biophilia hypothesis. The second is attention restoration theory. The third is stress reduction theory. And the fourth is ecosystem services. Basically, the biophilia hypothesis says that there is a human tendency to connect with nature and other living things. We know that their properties inspire beauty, pleasure, awe, fascination. We know that nature has these characteristics like fractal patterns that are easy for us to visualize and visually process because of their repeating patterns. So this is just one potential mechanism. Attention restoration theory. For people, natural environments may improve cognitive performance through the restoration of a limited cognitive resource, directed attention. So we basically, our attention is, we have a bucket of attention and we can use that attention. So nature can restore that attention. So it can restore that limited resource. Stress reduction theory. You all probably kind of inherently know the stress reducing benefits of being out in nature, being out in the sunlight, things like that. But we know from studies that nature does have an effect on our stress. It facilitates reduced physiological arousal, psychological stress, negative affect, and it increases our positive affect. And finally, ecosystem services. So these are any positive benefits that wildlife or ecosystems and nature have for us. So there's a lot of different types of these, right? Like it allows us to grow food. It can clean our water. It gives us nutrients. It gives us wood for warming ourselves. It decreases, if there are trees in a city, we know that that can decrease the temperature of the city. It can clean our water. It can clean our air. We know this can be a huge problem with the asthma rates and the high pollution rates in areas. It can provide opportunities for recreation, and it's beautiful. And we know that it just gives people a sense of community, a sense of place. So if you apply this to AARP has these 8 domains of livability that I think are really important to think about when we're talking about the health and well-being of people. If we're talking about ecosystem services, we know that outdoor spaces promote livability. So natural environments, parks, trails that can improve livability. Social participation promotes health and well-being and promotes a livable environment. We know that parks are places, or other natural areas are places that people can have shared social experiences. Same with civic participation. People need shared places to come together to be part of their community and to advocate in their community. Respect and social inclusion are so important for a livable environment. And we know that parks are places where people can feel social inclusion. They form connections. Transportation. This is particularly relevant in Maine right now with the transportation plan that's being developed. We know that greenways, bike paths, walking paths, all those areas that can get us out in nature are essential. And we know that it's important that people have multiple routes of transportation to get places. And the big one, obviously, when people think of getting outdoors in nature, they think of the ecosystem service. It provides us a place for physical activity. And a lot of you probably know the community guide. It says that parks, trails, greenways increase physical activity when it's combined with programs, community awareness, so telling people it's there, campaigns, or improved access. So getting people to these places and natural environments are essential to promote physical activity. So unfortunately, people do not have access to or experience nature the same. This is these are graphs from the Nature Gap from American Progress, and this is for the whole country. And these statistics show that people of color are more likely than white people to live in an area that is nature deprived by about 3 times. Low-income communities are more likely to experience nature deprivation. Native Americans in the Southwest experience disproportionate impacts from oil, gas, and coal development. And children in the US have far less nearby nature compared with the overall population. So already, if we're saying that nature is really beneficial, promotes health and well-being, but people don't have nature around them, that can cause some major issues to their health. And unfortunately, people have very differing experiences in nature. There is a great amount of resources on the American Hiking Society about racism in the outdoors. And I challenge you to watch and listen to these and read these resources by people who are leaders in this field. So you start to learn more about what people face and the difficulties people face when getting out of nature. We can't just say you should get out of nature, it's good for you. There's very real reasons why people won't. So it's important to start to learn about those reasons from the thought leaders. Also, inequitable access to nature. We know that people with disabilities are very unlikely to have equitable access to nature. There are a lot of disability justice advocates working to improve this, but right now, a great percentage of parks and outdoor spaces, beaches in Maine, trails, are not accessible for people with disabilities, and it's not prioritized. So it can be hard for people who already are at a higher risk for health and physical and mental health challenges to access nature, which is inherently good for them. So how can we change this? How can we promote access to nature? So I really like this table from Nature for All. What can we do? So as a healthcare community, for the society, we can invest in health nature promotion, and we can promote health and nature benefits. For our communities, we can support outdoor healthy living initiatives. We can lead nature initiatives for high-risk groups. And then for individuals, we can support clinical interventions like park prescription programs. And then the outdoor community, who are partners for this, right, with us. I think it's really important to kind of highlight that the health care community and the outdoor community are partners in a larger goal to promote health and well-being in our communities. So we can partner with the outdoor community who is protecting our natural areas and promoting the health and nature benefits. We can work with them to increase everyday accessibility to nature and diversify the outdoors. And we can work with them to partner with them for them to be able to provide on-site health-related programming. So that table on the previous slide summed up very nicely. So what can we do? We can engage and empower our local communities, ask our local communities what they need, what they expect, what they want, what they're looking for in outdoor access, and then give them the tools and support them in this effort to promote access to the outdoors. We can advocate in our own organizations and in the state or nationally for parks and protected lands within our communities and safer and easier ways to get to the park, and active transportation options, accessible parks, and inclusive, welcoming, and safe environments. And we can also hire and appoint staff and leaders that reflect the communities that these areas are in. So advocacy, protecting natural areas within our communities. Maine is very lucky to have a wonderful land trust presence, and we have 80 land trusts, and they have conserved over 2.6 million acres. And so what can we do to work with land trusts to support them, or even just advocate on behalf of them, support their work to get protected lands closer to people? These are some resources that I wanted to provide on my slides so you had access to them after this. One initiative that I really like is called the 10-minute walk initiative. This is obviously challenging in a state like Maine where there is a lot of rural communities, but how many people have a park 10 minutes walk from them? This is really important to think about because a lot of people don't have access to cars, or maybe only have one car and the person who is going to work all day is using it, or, it's important to think about having closer access to nature. There are ways to make pocket parks, mini forests, urban gardens. So areas that just bringing nature or shared natural areas closer to people is really important, because Maine has a lot of natural spaces, but do we have a lot of open shared public natural spaces for people close to them? And you can also work or join a park friends group. So if we have parks in our communities, but we don't have a safe way to access those parks, they might not be used the way they should be, or people could get injured trying to get there. So what can we do? Make sure the sidewalks to those parks are safe. There are crosswalks, there are traffic calming strategies. We know in Maine, there's a lot of roads that are very fast, right? And when we're trying to cross those areas, it can be particularly dangerous. So in places that, there's a park where you want people to be able to walk to it, using traffic calming strategies, increase lighting in an area so people feel safe walking to those areas. Maybe add bike lanes, add signage just to tell people how to get to the park and what direction the park is so they can orient to where the park is. And maybe improve connectivity. So create another path to the park, or, make sure the areas that there are, the signage points to all the different connections, the paths to get to the park. And I wanted to add these resources. The Safe Routes to Parks by the NRPA, the National Recreation and Parks Association, is a great resource. So I'd recommend that you check that out. Also, AARP has a wonderful walk audit toolkit. So if you want to learn how walkable your communities are, or not walkable, or if people use a wheelchair, rollable, you can use this audit toolkit. So public transportation, we know that public transportation is really hard in Maine, but there are plenty of people who don't have access to cars or who cannot drive for a variety of reasons. So are there options for them to be able to get to parks? This is a really great article out west. So I'd recommend that you read this article about how they used public transportation to get people to parks. Otherwise, those people wouldn't be able to access them. Advocate, support our greenways for active transportation and recreation. We are so lucky that we have the Eastern Trail Greenway in our state. And unfortunately, it doesn't cover the whole state, but there are other long trails and greenways that they're working on. So can we, as public health and healthcare providers, advocate on behalf of them to support these initiatives, to get more people out on these trails, using these trails, protect land to get on these trails, provide safe trails for people to use. So support bike and pedestrian infrastructure for active transportation. We talked about this a little bit, but the Maine DOT is looking for input on statewide active transportation plan. And active transportation gets people outdoors, gets people out in nature, and it improves their physical activity, right? We know that this reduces obesity, risks for diabetes, cardiovascular disease, and they're really particularly important in low income and minority communities, or communities that have a high percentage of new immigrants, because those community members are less likely to own vehicles, or unsafe streets may pose a barrier for people to use transportation. So we as healthcare providers, this is part of our lane, right? Is if we're telling people you should be physically active or you should be getting out into the outdoors more, but there's not a safe way for them to do it. We should be part of the advocacy work at making sure there are options for people. What can we do to improve the accessibility of natural spaces? So in Kennebunk, I was able to work with the town of Kennebunk to add Moby mats to one of the beaches, Mother's Beach, in order to improve access for people using wheelchairs or other assistive devices, as well as strollers, wagons, onto a beach in Kennebunk. And I know there are other beaches in Maine that have this as well. And I think it's important that all beaches have this option. So people, with mobility impairments have access to the opportunity to use these spaces. In Brunswick, people have advocated and successfully built an inclusive playground, which is an amazing accomplishment. And in Kennebunk, there's a wonderful accessible trail at Hope Woods, which I take some of my patients out there, and I do a lot to try to promote that asset to people. People with disabilities should very much be able to get outdoors and enjoy the outdoors just as much as people who don't have mobility impairments. And if there's one thing, there's a disability advocate named Siren Naga Kyrie. They made a great statement that says, if there's one thing that I wish all hikers knew, is that building accommodations and universal access into the community benefits everyone. So what we can do is starting to support these conversations, bring these conversations up within our own communities, make sure we're prioritizing accessibility into new projects and potential renovations of projects, or just making accessibility the center of a project, right? We can use our voices to do that. I wanted to share these resources with all of you so you have the knowledge and more of the understanding on how to do this. So the United States Access Board provided accessibility standards for federal outdoor developed areas, and these standards are best practices, not just for federal areas, but also for state and local areas for the outdoors right now. And this webinar on the page called Accessibility from Entry to Exit is a wonderful webinar that I would highly recommend you watch about what accessibility means when people come to the spaces. And the American Trails Hub has a trail accessibility hub. So there are a lot of places that you can go to educate yourself and learn more. And then the Park Access Campaign by the National Recreation and Parks Association also has a lot of resources. And please, if you have any questions, I'd be more than happy to help in any way I can or direct you to the best person for those. So please reach out to me as well. What else can we do? Elevate people with disabilities, elevate their voices, their expertise, their lived experiences. So I've had the pleasure to meet Enoch a couple times, and he is working to make main trails more accessible. So he actually gets invited to trails, or he goes himself and he rides the trails and analyzes how accessible they are and provides recommendations for ways they can become more accessible. So in addition to, making trails more accessible, it's important to promoting these trails. So one of the hardest things is information sharing. People don't know trails like this exist. So a lot of people may be like, you know what, I really would love to be able to hike again, but there's no way I could do it. And people just may not know that there are accessible trail options available. So it would be great if we could all start sharing these resources and sharing the inclusive programming that's available, so more people know about these, and this becomes, a normal part of our practices and our advocacy work. Oh, sorry, Al. I clicked on the link.
And Katie, as you're getting back in, just, about some minutes left.
Yes, thank you. Basically, clinical interventions, as a clinician, I think about these. We can educate people, bring nature indoors, bring treatment outdoors, and apply this in different settings. So I can share what the local parks and trails are for people, what the accessible trails are. I can problem solve to help them get outside. We can also bring nature indoors, encourage people to open window shades, decorate with potted plants and nature photos, listen to nature sounds. We can start advocating for our hospitals and clinics to have outdoor treatment areas and just work outdoors more often. And we can use programs like park prescription programs. We want people to walk or roll or move outside, so we can use park prescription programs to do this, or refer them to community programs that are already doing that, like the Parks and Recreation programs in all of our local communities. Silver Sneakers has a great program. And there's walk with a doc programs where doctors, physical therapists, medical students will help walk, will lead a walk. So people will maybe feel more comfortable walking with them, and also break down those barriers between community members and medical professionals. So kind of the summary is that we're all working to improve community health and well-being. Public health professionals, healthcare providers, park and rec professionals, environmentalists, community members, minority rights advocates, landscape architects. Like, there's so many people working to promote community health and well-being. So I think it's important to expand what we think of as public health and bring all of these people in to work on our shared missions and goals. Here's some recommended reading for all of you. I'd highly recommend these 4 books and a lot of other books. And these can be found in my slides that are posted, and some additional resources. And thank you all so much for your attention. And thank you, Heather. I really appreciate being here today.
Thank you, Katie. This is such a great presentation and wonderful information. Just a reminder, we do have time for questions, so please put those into the Q&A. And Carl also shared a link to the main Trail Finder in the chat so folks can see it there. We do have a couple questions that have come in so far. Can you describe the dose of nature that people need to reap the health benefits? Is there a minimum amount of time required? And does more time yield greater benefit?
Yes. So about 20 minutes a week is really important, but we know that even 5 minutes can get people starting on those benefits of nature. But try for 20 minutes a week. And if you can get to a longer 2-hour chunk, that would be great. But even shorter chunks, or even, like I said, bringing nature indoors for very small amounts of nature, like, a site out a window, having people put bird feeders out their window, some photos or artwork of nature can really help with that. So there's a wide range of how we can get nature into people's lives, but I'd recommend starting with at least 20 minutes.
Thank you. And a follow-up to that, is there research established time of diminishing returns for health benefits?
I would have to get back to the person who asked that question. I have a couple resources I can send them. I'm not sure exactly if there is. I do know that it's important for people to want to be in nature. If people do not want to be in nature, do not feel like they are away from their daily life, that's an important thing. They won't start getting those beneficial effects of nature. So there is a component where you just can't put a bunch of people out in nature that don't really want to be there. But I do know that going out and going for like a long, like week trip can be very beneficial for people to be out in nature, to really disconnect for 48 hours at least. So I would have to look at the research about what the maximum amount of time is, though.
Great, thank you. And so you provided a ton. One of the questions is, can you talk more specifically about what's happening in Maine? I think that came in a little early in the presentation because you've provided a lot of resources. But if people wanted to get involved specifically in Maine in some of this work, do you have 1 or 2 action items that they could do, organizations to plug into others other than the ones that you've suggested?
Yeah, no, thank you for that question. What I think is really important is starting to connect with our own local parks and recreation professionals, because they are public health professionals. So working with your local parks and recreation professionals or your local land trusts, I think is really important, because this is a conversation that's starting that needs to keep going to start changing this culture. So just connecting with people and recognizing that shared mission that we all have, and those shared goals we all have, and how we can collaborate and use our kind of comparable skills to promote health and well-being. So I definitely say start local and try to hook up with your local groups.
Great, thank you. And that was perfect timing. We're right at 10:50. So thank you so much, Katie. Please don't forget to take the session evaluation in the chat. And we will take a brief 1 to 2 minute break before we begin our next presentation on gender equity. So please take a brief pause, go stretch, go stick your head out a window and get some fresh air. And we will be right back at like 10:52. Thanks, everybody.
Thank you.
Hello and welcome back. I'm excited to introduce our next session, digging deeper on gender inequities, disaggregating data to understand health disparities. And we will hear from Jess Maurer, the Executive Director at Maine Council on Aging, and Dusty Homan-Sprague, the Executive Director at the Maine Women's Lobby Education Fund. Before I turn it over to them, just a few reminders that you've probably heard frequently at this point. You can access closed captioning underneath your video stream. Use the chat to interact and put any questions in the Q&A. And I will also be providing a link to evaluate this session in the chat as well. So thank you all so much. And I will now turn it over to Jess and Dusty.
Excellent. Thanks so much. And we have nothing to disclose. So I thought we would start there and also say, I think they're going to drop the link to the chat. I'm sorry, in the link to the report in the chat so that you can actually access the report that we're going to be speaking about. And Desi also thought it'd be a good idea that we start by saying sort of why we even caused this report to happen. And I think for me, it is that during 2020, and 2021, some other things happened besides COVID. And one of them was really COVID having a pretty significant impact on our direct care workforce. And so in talking and advocating about that direct care workforce, I had reason to go deep into some demographic data about the economic status of women in particular who could not afford to pay out of pocket for home care, and was really shocked by sort of what I found when I started disaggregating the data. And then I started incorporating that data into a project we're doing, which creates, it's called the Municipal Data Across Sectors for Healthy Aging. And it creates a data dashboard for individual communities in Maine. And so we started looking at the number of women who are living alone and their income. And again, we're really quite floored by what we learned. And then finally, we had PHI, which is an international organization looking at the direct care workforce, come and present at our summit in 2021. And they showed us a screen print of the number of working age women in Minnesota and compared to the number of older people in Minnesota. And I thought, oh my gosh, I have been not looking at the right number. I've been looking at working age people, but not working age women. Because those are our traditional care providers. And so all of that put together, and then I started looking at that data in relation to individual municipalities. And I started saying we have some significant challenges here, and we should think about talking about those. So I talked to Dusty. So I'm going to turn things over to Dusty to say, why are you here, and why did you want to do this work?
Hello, I'm so happy to be with you today. We wanted to do this work because I think we keep hearing that maybe the time for the women's lobby has passed. Like maybe gender equity has been achieved. We see that we have more and more women in leadership positions and positions of power in the legislature. And yet, for those of us who are doing gender equity work, we know that that is simply not so. In fact, the needle has not moved at all on numbers of women living in poverty, numbers of women experiencing violence, numbers of women experiencing ill health effects over the lifespan. And we know that those things are all connected. They're not incidental, like one thing happening here at this time in the life or one thing happening here at a different point in the life. It's actually connected over the lifespan, and it's connected to what Jess is seeing at the Council of Aging, sort of culminating in later life. And we wanted to really begin the process of thinking about how we can put these pieces together and make those connections so that we're building more comprehensive systems and comprehensive public policies to address it. So I was thrilled to be a part of this project. We will jump in and share. So we worked with the Cutler Institute of Health to pull together an assessment of existing data. And they were able to look at a variety of different pieces of data. You'll find the methodology in the full report. But it reflected back some fascinating trends, some of which we knew, obviously because we're in this work, and some of which was a surprise, I think, even to us, to see it presented in this way. So some of the things that we knew, and yet in this visualization. So as I said earlier, we know that women are still significantly more likely to live in poverty as compared to men. That's true across the lifespan. Next. We know that in the same way Jess mentioned, we need to disaggregate and look at men versus women and different gender identities. We must also bring a race and ability analysis into this as well. It's why we're looking to disaggregate across age ranges, across ability, across gender, and also across race. Because when we add on the race analysis here, we see that women of color are experiencing dramatically higher rates of poverty as compared to white women across all age groups. So we're layering on those different levels of oppression, and it shows. We see that the median annual income continues to be less for women across all ages, and that is compounded across the course of a lifespan. You can see here that that disparity actually grows. Next. And some of the reasons for those disparities are that we see that women continue to make up a disproportionate share of low-wage occupations. So you'll see here that women are larger parts of lower-wage, lower-paying occupations like receptionists, healthcare supports, maids and housekeeping. But what's really compelling here, actually, about this information is that even within those occupations, women are still making less than men. So it is not only that women are concentrated in low wage occupations, it's that even within those, they're making less. When we bring these numbers to Maine, we see that they largely echo what we understand to be true across the national environment. So those were national stats. When we bring them to Maine, we see the same. Still, women are more likely to live in poverty as compared to men. And that in older age, the poverty rate decreases for older men, but goes up for older women. Women's median weekly earnings continue to be less than men's. So there was a high in 2018 of women making 87% of what men are making, but it's actually begun to drop now. So back to what I said earlier about like things were improving, but we are not there yet. And in fact, the needle is moving now in the wrong direction. We don't have a race analysis for this here in Maine, but I think we can all rest assured to understand that when we add that layer, the numbers show that sexism plus racism add up. And then we know too that across, oh, this is another really interesting, it's what I just mentioned about over the years, we see, if you look down at the bottom, that difference, 7,000, 7,000, 6,000, okay, yay, we're moving in the right direction. But wow, in the course of just 2 years, the disparity between women's and men's annual income is actually increased by double. The reasons for this are many, but at the forefront of it, it is really the invisible and often unspoken care obligations that women really provide for our entire culture. Fascinating article a couple of years ago that came out that said other countries have safety nets, America has women. So women are citing that childcare, family, and personal obligations are what is forcing them out of the workforce, forcing them into less flexible, lower paying jobs, forcing them into fewer hours and part-time hours. So you can really see the dramatic difference there in that slide. As a result of caregiving, 58% of caregivers going in late, leaving early, taking time off, a quarter moving from full-time to part-time, taking leaves of absence. And we have to remember that only about 15% of people in Maine are able to access paid extended absence for medical or family leave. So when people are taking a leave of absence, that is not paid time. And these are the kinds of things that accrue over the course of a lifetime and lead to the slides that Jess is going to share with us. We see that this financial strain, physical strain, emotional strain of having to step out of the workforce or retire early really adds up. And it's going to start to show in different ways as well. Right now, I think we often think about these things as an impact on the individual person and their own losses, but we have to understand that these ripple out across our whole community. Jess, I know this is one of your very favorite slides, so this is where I'm going to turn the baton to you.
I'm not sure I have very favorite slides, but yeah.
Well,
but I do want to go back to one thing that Desi said that I just want to underscore as we move into the slides that really demonstrate the impact of many of the things Desi was just talking about, is that when women leave the workforce to provide care, for instance, for their kids or for older relatives and spouses, they get a penalty. They are no longer paying into Social Security and then ultimately may get the lowest amount of Social Security available, whereas older men continue to work and pay into Social Security and are earning more through Social Security, which is, of course, the economic safety net for older people. later in life. The same is true for retirement benefits. And I think what is sort of driving much of the data that I'll be sharing. So this slide is definitely one of, right, the canary in the coal mine for Maine in relation to our direct care workforce. And really, Maine has about 3 working age people to every person over the age of 65. That number has been declining for the last many decades. When you look at only women who are the traditional formal and informal care providers, this number drops to 1.49 working age women for every one over the age of 65. So really looking at this slide, we're seeing Maine is an outlier in relation to this trend, although not in Northern New England. Northern New England, this is completely consistent, but it's something we need to pay attention to. Here, we're looking at that women over the age of 65 live alone at a rate double that than men. This is over the age of 65. In Maine, that's 50,000 women who live alone, and their median income is significantly lower than the men who live alone. And I'm going to underscore why you might look at that number and say $5,000 isn't significant. I'll talk a little bit about why that is. And so the median income is $22,000. So here's where I want to share something called the Economic Elder Security Index, which was created a number of years ago by people who said, look, the federal poverty level is masking the poverty of older people. And so they dug deep and created an algorithm essentially that looks at the cost of living. And when we're talking about for basic needs, we're talking about housing, transportation, healthcare, food, utilities, and heat. And then this Elder Economic Security Index looks at whether you're living alone or you're living in a couple, whether you have good health, poor health, excellent health, and whether you're living in a home that you own with or without a mortgage, or if you're renting. And so what this slide shows you, which is a very complicated slide, but the message is pretty easy, which is that essentially all of the women who live alone at or below the median income in Maine who are 65 and older do not have enough money to meet their basic needs. And just those people who are living in a home, older women who are living in a home without a mortgage, who have excellent health, have just enough income to meet their basic needs. But otherwise, we're talking about 25,000 people, 25,000 women in Maine who don't have enough money to meet their basic needs. And I will say that most of them probably will not qualify for means tested benefits right currently. So again, this slide tracks what we saw previously with increased poverty rates, but really want to emphasize that we're talking about the increased poverty rates for women over the age of 80. Here we see that women are more likely to live alone as they grow older, while as men are not. And here, men over 80 are 2 times more likely to live with a spouse or a partner than a woman. And while very few older people in Maine actually live with family members, women are more likely to live with family members than men. Women over the age of 60 who live alone have a poverty rate 2 times that of men who live alone. And I will say that's very much likely due to the low wage types of jobs that women have done historically that Desti was pointing out earlier, as well as not earning as much as their male counterparts in the same jobs. And then ultimately, which actually this surprised me considerably, across every disability type, women are much more likely to have 1 or more disability than men later in life. And again, this is very likely due to the hard work that typically women do across their lifetime, including care work and work that is on their feet, as opposed to men who have traditionally have jobs that are at desks. Or less, or in cars, or so it's a wear and tear on a body. And then finally, this is the cost of care in Maine. And I don't know if any of you know, but Maine actually has the distinction of having being the most costly state for home care And I think we rank 48th in cost of care for nursing home facilities. This demonstrates that if you could find care, and by the way, there are very few adult day programs around Maine, but if you could find care and you are a woman who lives alone, you are very unlikely to be able to afford care. And so really points out that we have a significant number of people who will need care because of the higher disability rates, who will not be able to afford care, and really, I think, leads us to believe that there are certain public health issues that we really need to be paying attention to. So finally, before we stop talking and begin having a conversation about what we can do, I wanted to share, so I mentioned we're doing this data dashboard project, and so wanted to share a couple of slides from our data dashboards. Here, I'm underscoring that in some places like Millinocket and Eastport, they have considerably higher populations of people 65 and older than their counties and the state. Eastport actually has twice as high, their population 65 and older is twice as high as the state's. And as we look at the working age population and pull out the working age women, you'll see again that Millinocket and Eastport have fewer than one woman for every person, working age woman for every person over the age of 65. Again, really troubling. And then this part really, again, looks at those pieces that we've just been talking about, the number of older women and men who live alone and by percentage. And you'll see, again, significantly higher rates in some places. But look at the poverty rates. I mean, the poverty rates in Millinocket and South Portland of older women are essentially 90%. So the people who are poor in those communities who are over 65 are women. It's really important to understand that. And then when you look at women and men 65 and older who live alone, again, in these communities, Millinocket and South Portland, you see drastically different percentages, right? $20,000 difference as opposed to a $5,000 difference statewide. And in Millinocket, it's because, of course, men typically worked at the mills, and they have pensions, whereas women do not. And so if they're on their own, they have a significantly different economic outlook than men in their community. So we're now going to move to talking about what do we do about what we've learned through this report. So I'm going to turn things back to Desti for starting this off here.
All right, thanks, Jess. So we really look at those care systems because we know that it's care and caregiving that in many cases is keeping women, pulling women out of the workforce. So we need to really build the safety net systems that other countries have. In fact, we're one of only 2 developed countries in the world without a system for paid family and medical leave. So someone has figured out how to solve this problem. And 12 other states have done it, and we are prepared to do it here. And it's not just paid family and medical leave, it's all of those systems that ensure that families and communities get the care they need without externalizing it onto individual women to have to provide those services. So that includes childcare, adult care, lifespan care. Next. We know that not every woman needs to, or not every person needs to be, you know, in the workforce while someone else is providing care to their family. Like, people want to provide their own care in their own families, and they should be able to do so without experiencing such a powerful loss of income, powerful loss of accrual of savings, the Social Security loss over the lifespan. So we need to find ways to make sure that people can actually provide the unpaid family care without sort of coming to harm over the course of their lifetime. Something like Social Security credits could be an option. We also just launched a caregiver grant program in the state of Maine that does $2,000 reimbursement for real costs. So this is a pilot, but these are the ways we need to start to get creative. And we also know that in the caregiver field, almost all caregivers, whether it's direct support workers or childcare providers, are women. And we know that these are some of the lowest paying professions. in our community, even though we know everyone needs it, because without care, all other economic growth and work grinds to a halt. So we need to make sure that the people who are providing that care professionally are treated as professionals and compensated as professionals, so that we're not externalizing the needs of care on them either. And then I think this is the place where, we have to acknowledge that sexism and ageism and racism are all teaming up to put the costs of discrimination on individuals in our culture, and we need to start recognizing those costs. I know that, Jess, you have a lot to say here as well, and so again, this is where I'll pass the baton.
Sure. And
And
I
I
just
do-
want to say,
Oh,
oh,
just
go
want to
ahead.
let you know you have 5 minutes left.
Thank you so much. And we are almost done. Yay. So I just want to say we talk to employers all across Maine about issues related to ageism. And we talk to older people as well. And what we hear consistently, particularly from older women who have left the workforce to provide care in some sort of way, is that they cannot get back in with their former type of employment, and that they are only offered lower paying jobs, which they have to take because they need to work. And so they end up working longer, again, harder on their bodies, working longer for less money if they hadn't left the workforce. So definitely, and we need to address what we hear directly from employers as age discrimination. We don't want to hire older people because they don't understand our technology. They'll want to, retire early. We want more of a long-term person. We hear all kinds of things that are actually illegal workplace discrimination based on age, and definitely a piece that we're going to have to address. Obviously, we need to reform the long-term care supports and services system, specifically from a lens of equity, and looking at the pay inequity, a gender-based pay inequity across a lifetime. And so we're going to be recommending that we use the Elder Economic Security Index as a standard for benefits as opposed to the federal poverty level. Again, targeting programs specifically for older Mainers who live alone, programs that we know help reduce accidents, reduce health problems, increase access to accessibility to healthcare. We really need to target some of these services to older Mainers who live alone, because generally speaking, while we will benefit some men, we will be benefiting more women, obviously based on our statistics. Public health recommendations specifically, really want to encourage you to disaggregate. We have to start looking differently at data, particularly looking at gender variations as well as age variations. As an example, there are about 93% of people over the age of 65 that have a driver's license. So that might lead you to believe, right, that we don't have a problem with people driving. But if you look at people over the age of 80, it's about 73% of people over 80 have a driver's license. So we have to be doing that. We have to stop looking at 5 decades of people who are 65 and older and think that they're all the same. And this report clearly demonstrates why we need to do that. And then finally, I would encourage you to learn about the Elder Economic Security Index and how you can use this in your work to begin to support older women in particular who are experiencing significant challenges. So, and we've already talked about this. So finally, address ageism and sexism within all systems. And we would be happy to work with you in figuring out how to do that. So, and we've talked about supporting the caregivers. So I think I'll stop here and see if we have any questions. Does that work for you, Dusty?
Sure thing.
Great, thank you both. Not data you always want to see, but very important. So thank you for your presentation this morning. We do have a couple questions in just a minute to answer them. This one might be fairly quick. Are the wage disparities reflective of men and women working the same position in jobs, or are they just wages in general?
No, it is reflective. Not only there is a wage disparity across all industries, but even within industries, there's a wage disparity. And we know that when women move into traditionally male-dominated fields, that wage disparity starts to show up and wages decrease as that work is devalued.
Thank you. And then next question, is there any data on sense of self-worth that women experience as a result of having to leave the workforce and take on caregiving responsibilities?
I'll quickly say I do not know of it, but we do know that there is a clear link between increased depression and anxiety for women who are providing caregiving roles, but not sure if it is about the workplace or about the challenge and isolation of the kinds of work without systemic supports.
And I don't know specifically about caregivers. I can tell you conversely, there's been a lot of really incredible research done on purpose and longevity, and people who live with purpose, i.e. a reason to get up in the morning, will live essentially longer, 7 years longer with fewer cognitive problems and fewer health problems than people who don't have purpose. And I would imagine that people who are, I don't know, scientists of some sort who love their job, or advocates like we are who love our jobs, if we're called away from that and are doing something totally different that we are not called to do, i.e. care, then I would imagine we wouldn't feel like we were meeting our purpose in our hearts in the work that we're doing. So I have to believe there probably is research out there. I just don't know it specifically on this question.
Thank you. I appreciate that answer. So we are at time. Thank you both, Jess and Dusty, so much. This was a great presentation with a lot of valuable information. Please, folks in the audience, take the evaluation that's in the chat, and you can also find the report there as well, and the Elder Index that Jess mentioned too. We will take a brief 1 to 2 minute break as we transition to speakers, and we will come back to talk about oral health equity. So we will see you in probably around 11:23. Thank you. Welcome back, everyone. Thank you for joining us or continuing to stay on in this session. I'm excited for our next presentation to welcome Regina Phillips, who is the Chief Operating Officer of Cross-Cultural Community Services. She'll be presenting this morning on oral health equity collaboration, community partners, and plans. Again, just a few reminders before I turn it over to her. If you don't know yet, there is closed captioning underneath the video stream. You can use the chat to interact and the Q&A to ask any questions, and I will be putting the session evaluation link in the chat as well. So thank you all, and thank you, Regina. I will turn it over to you.
Thank you. I'm so happy to be here, and I just want to give a shout out to the two previous presenters. They just did an excellent job and really great information that they were able to share. I know I took a lot away from both presentations, so thank you. So I'm here today to talk about oral health and how it relates to race and equity and populations. Disclosure, the presenter have nothing to disclose with regard to commercial relationships. So first, I want to begin with giving you some statistics around the Black, Indigenous, and people of color population as it relates to healthcare, because members of the Black community have not always had a positive relationship with healthcare providers, and it's even worse when you talk about oral health. And so, just to give you some information, according to the 2018 National Healthcare Quality and Disparities, Black American Indians and Alaska Natives and Native Hawaiian Pacific Islanders receive worse care than whites for about 40% of the measures. In a recent article published in the Pullman Press Herald, and so basically I want to give you a full picture, and so that's why we're going to be talking about in these statistics healthcare along with other disparities. So in a recent article published by the Pullman Press Herald, they said they outlined our disciplinary rates. And basically what it said was that Black students are being disciplined at higher rates than our white students. And because of that, it has a long-lasting, devastating effects on our Black youth. I mean, if you're going to school and you're constantly being disciplined and you're constantly hearing that you're not as good, or whatever as your white counterpart, that is going to have some devastating effects on you, and also your decisions educationally as you go further. Not only do we have the disciplinary rates we're dealing with when we talk about education, but then after that, we're also historically have been more arrested more than our white counterparts. And so when you put all of that together, when you put the disparities in healthcare, when you talk about the education, when you talk about the fact that Black youth and Black people are being arrested more than whites, it really creates this inequity. And so we have that happening. And then when you bring it down to me, and we talk about COVID in the pandemic, BIPOC members had the highest rates of COVID across the country. I'm not saying just in Maine, but it was across the country. And so even though we accounted for 713 of those 2,578 COVID cases in Maine in 2020, we only make up a population of 1.4% in the state. And so, and not only that, but across the country, the African-American population is only 13.6%. So you can see how all of this affects how this affects the Black population. So that's, again, giving you some of the statistics on the overall picture of what's happening within the Black population, especially when it comes to health and other systems. We then have to bring it down to oral health, right? Because that's why we're here. So we have to bring it down to oral health. And so, as you can imagine, just like all of the other health disparities that Black folks are dealing with, we also have access to oral health care at lower rates than our white and non-Hispanic Mainers. And so you can see that this story is across a lot of the sectors. In 2019, 59% of Black and African American high schoolers, 66% of American Indian, Alaska Natives, and 69% of Hispanic high schoolers had a dental visit compared to 81% of white high schoolers. And this isn't information that we just said, oh, let's figure this out, but this came from the Maine Integrated Youth Health Survey, the survey that we conduct in Maine every 2 years. So that gives you some information on the student and what's happening with them regarding oral health. Among adults, only 46% of multiracial Mainers and 46% of American Indian, Alaska Native Mainers saw a dentist in the past year, compared to 65% of white Mainers. And not only that, but I think within our populations, this is just another thing. So, we're thinking, first of all, we don't trust the healthcare system. We're being treated unfairly within the healthcare system. There were experiments that were being done in order for researchers to continue their research within healthcare. And so we have all of this stuff happening up here with healthcare, and nobody is really paying attention or paying little attention to oral health and how oral health affects our health. And so again, with the pandemic, with the economic downturn due to COVID-19 and the pandemic, this was especially harmful to the BIPOC community. And not to mention the fact that dental offices were closing. We couldn't get to school, right? We all had to do hybrid, or we all had to be on the box. I call them the box. And so our school-based programs and all of those things, they also took a hit, which meant that Black people in the BIPOC community also took a hit and weren't able to access the oral health and the healthcare that they needed. So what do we do? What do we do about all of this? So hopefully many of you have heard of the Children's Oral Health Network of Maine. Becca Metachovic and Kaylee Huss are the folks that are behind this amazing work. And Cross-Culture Community Services, myself, will get, and Decca Dalak and Abir Abraham, the co-founders that make up Cross-Cultural. We had a relationship with Becca and Kaylee. We had a relationship with Children's Oral Health. We knew who they were. We knew what their work was. And we said, well, wait a minute. We can tackle some of healthcare, but it's just so incredibly overwhelming that really what we want to do is take a look at oral health and see what options we have to make sure we're educating our communities about oral health and letting them know what the connection between oral health and overall health is. So what can we do? How can we make this happen? And so the Children's Oral Health Network, if you haven't heard of it, their mission, we are united by a shared vision, ensuring that all children in Maine can grow up free from preventable dental disease. Okay, the program was founded in 2018, and it has was established using a network approach to leverage collective action to transform Maine into a state where together we can meet the oral health needs of all children and families, prioritize prevention, because a lot of this is about prevention. If we can get people to get to the dentist every 6 months or every year, then we're doing a pretty good job. And integrate oral health as an essential element of overall health and well-being. And that's really what Cross-Cultural is really looking at. How can we figure out how we can incorporate oral health into our overall health? Because a lot of people won't go to the dentist because of a lot of the reasons why I told you. So here we have Cross-Cultural. And so Cross-Cultural was established in 2018 by myself, Decca Dalak, and Abir Abraham, who've been doing this work for a very long time. Actually, all three of us are from three different countries. Decca, some of you may know, she's from Somalia, Abir is from Sudan, and I'm from the United States. And each one of us bring our own education and our own knowledge and our expertise and experience to this work. And we're also very, very strong advocates for social justice, policy and system change. So again, all of us, especially those disenfranchised persons, can be afforded fair and equitable treatment. And so through our organization, our mission is to promote social inclusion, improve equitable outcomes in systems and reduce the social determinants of health for culturally and ethnically diverse communities through outreach, education, and advocacy. Because if we don't advocate for ourselves and we don't advocate for our community, nobody else is going to do it. And so there's kind of two arms to us. We do some training on equity, diversity, and inclusion. And then there's also the health side, where we have some grants to do some COVID vaccine work. And so what happened was cross-cultural got together with Children's Oral Health Network, and we said, what can we do together? Children's Oral Health Network gave us a small grant for us to look at how we can train oral health practitioners, right? And open up those relationships, because it's all about trust. And so we wanted to make sure that the folks in the community, the folks in my community, were able to access oral health. And in order to do that, we knew we had to do something with practitioners to teach them about our community. And we also needed to teach our community about the oral health practitioners. And so that's really why we came together. However, after looking at this, we realized we could do so much more. So we brought on Cumberland County, the public health, and we said, what can we do? What can we do locally, and what can we do in the county, in Cumberland County? Because we were all focused in work in Greater Portland, and we knew it had to be a little bit more than just us. And so we formed the Oral Health Equity Collaborative in early 2022. And it is led by us. We're the facilitator of the Oral Health Equity Collaborative. But we also have folks involved in this who are BIPOC led. So even though we're the facilitator, we know that we have to have other community members involved and other partners. So we have Maine Access Immigrant Network and the City of Portland Public Health. Those individuals along with us, they're community-based organizations that are providing services within the BIPOC community. But then we knew we also had to bring along the oral health practitioners, those folks who are actually out in the community serving our communities. And so we brought along Community Dental Health, Greater Portland Health, and Mainly Teeth as oral health providers, because we can't do this work alone. We need everybody to help us try to figure out how we can get this, how we can look at oral health differently. And then we thought, well, we also need help within the workforce, because if we're not looking at the workforce and if we're not looking at folks within in oral health that's doing this work, then where will we be? And so we also wanted to bring on the University of New England. So again, so we're all looking at this collectively and collaboratively. And so this is just some more information on our partners. These are all of our partners. We have signed an MOU with all of our partners. We also have the state involved. And so we have the Office of Population Health Equity. We have Rural Health. We also have the Maine Primary Care Association. So we really and truly tried to look at this and see who can help us implement a plan where we're specifically looking at the BIPOC community and helping them access oral health. And so what we did is we created an implementation plan. We created a plan and with some goals. And we said, this is how we want to do this work. And so OHEC provides mutual support and learning to strengthen the capacity of oral health centers to serve BIPOC community members effectively. And not only that, but increasing access to culturally tailored quality care. Because if we don't, then they will not come. There will not be any trust in the communities. There will not be any relationships. OHEC members engage collaboratively, understanding and finding ways to dismantle systemic racism, especially as it impacts the BIPOC community and oral health disparities. We have to start dismantling some of these systems or folks will not come. They will not access. Our statistics will be just as bad as they are today. And additionally, OHEC engages in collective action with Cumberland County, just to explain that, the Office of Rural Health and Population Health, and Maine Primary Care, so that we can improve the infrastructure that supports oral health for all Maine adults with a focus on those who are historically underserved. So again, we created this implementation plan, and I think you'll be able to have access to it. But we created this implementation plan with three goals. And overall, what we wanted to do, we wanted to make sure we looked at prevention, because prevention is key. We wanted to look at prevention and how we could make sure that we were looking at that prevention delivery service for not only youth, but for adults all across Cumberland County. And that's why it was so important for us to partner with Cumberland County. And so we have an implementation plan that cross-cultural is facilitating. And it's a Greater Portland implementation plan that we're saying, okay, how can we engage more of the adults in this process? What can we do? How can we educate them? How can we educate our oral health practitioners to make sure that they are culturally competent? But we had to look at Cumberland County because they're looking at prevention across Cumberland County, and they're also looking at kids and and students and how they can also have prevention for children. And so it's not that our implementation, it's not that the Oral Health Equity Collaborative, it's not like we didn't want to look at that. It's just that we could only do so much within Greater Portland. And that's why we had to partner with Cumberland County, because they were looking at it countywide. And they were also bringing along the fact that we needed to engage parents in order to provide some prevention for their kids. So in that second bullet, helping adults who have gone throughout without care to make the most of the new comprehensive Maine Care benefits. And so we are very excited that Maine Care now they have a Maine Care allowance for adults who need oral health. And so we had to take a look at that as well. How can we get involved? Because cross-cultural, because we represent 3 different communities, even though they're intertwined and integrated, we needed to say to them, okay, you can trust everybody. Okay, this is what's coming out. And make sure that you sign up for Maine Care so that you can access this incredible new thing. And so the goals. So we created 3 goals. The first goal is to grow capacity for providers who take Maine Care and sliding scale fee to serve more and all families. Because as we know, I don't know if you've tried to make a dentist appointment, but I tried to make one in December and they told me I'll see you in July. And so because of the pandemic and because of you know, a lot of things happening, we wanted to make sure that we were able to grow those folks who were taking Maine Care and those folks taking sliding scale fee, so that we could make sure that the members of the BIPOC community and the African American community were able to actually get a provider. Another goal around the implementation plan was to strengthen capacity of providers to provide culturally relevant care to those who face additional barriers to oral health. Now we know that there's all kinds of barriers, right? There's transportation, there's overall health, there's employment, right? If we have folks that are in entry-level positions, they're not going to be able to take their children to the dentist regularly because they're not going to get paid for that. So we know that there's all of these barriers to oral health. And one of those barriers, not only on what's happening within the community, but one of those barriers are providing oral health practitioners with the fact that they need to open up their dental offices to provide more care for our BIPOC community. And in order to do that, they need to understand our communities or have some training on what's happening within our communities. And again, I'll pick on Decker Bear and I, we're from 3 different countries. And so we have 3 different things to share with people on our communities. And so it's really important for our oral health practitioners to hear all of those. And the third one was to strengthen capacity for community-based organizations to help their communities access care and receive oral health. That's the overall goal, is to have access and receive and achieve oral health. And to develop relationships with provider organizations to continually improve how the providers do their work. And so within this, part of the goals here are prevention services to all kids in Cumberland County. That's one of the goals that our Cumberland County partner is going to be looking at, and to prepare oral health providers to take more adults to the new Maine Care Oral Health Alliance. It's really important that we take a look at that. And it's really important that we let people know, now is the time, even though you might not be able to get an appointment for several months, it's really important for you to sign up, and it's really important for you to do that. Goal 2 is around, like I say, goal 2 is around making sure that we train our healthcare, our oral health practitioners on cultural competency, and also build the workforce. We need to have that workforce. And the third goal was to continue to facilitate the Oral Health Equity Collaborative and look at the goals regarding community health workers. The goal includes the disabled community, but it's not a focus. And so I'm looking at the time. I think I only have 5 minutes. I guess when just somebody said 30 minutes goes by fairly quickly, I guess they were not lying. So
we have a couple minutes wiggle room. You're all right.
Thanks. So I'm just going to quickly go over this. Because I really want to get at what we do now. And so systemic racism is the driver of all of this. It's the driver of the social determinant of its health, right? And so even though we talk about the social determinants of health, we often exclude racism. We often exclude how we're going to tackle racism when it comes to the social determinants of health. And we've known for decades that racial inequities in oral health exist. It exists across health systems, and it exists across all systems. And in order to improve that, we really and truly need to take a look at our policies and procedures in order to reduce inequities. Just as racism directly affects communities across communities, is access to safe water, healthy food, and public transportation, as we heard from our previous 2 presenters, who did an amazing job in connecting racism to these systems, even when it comes to healthy food and walking. Anyway, sorry. Systemic racism is also at work in dental education settings. And so we don't have a lot of folks within the dental school wanting to become dentists. And so again, that's something we have to look at. And so I'm gonna let you read, because I'm really nervous about the time. Boy, this goes by quick. And so what do? We need to recognize even subtle forms of bias, discrimination, and inequities. We have to recognize it. We have to recognize it. And then we have to respond. We have to respond to bias, discrimination, and inequity in a thoughtful and equitable manner. And sometimes that's easy to do, and sometimes that's not so easy to do. Because sometimes you're in a room with with your friends or whatever, and you're like, is now the time for me to bring it up? And so you have to figure out, when to do it and when to not. And we suggest that you just be brave and do it. We have to redress the bias, right? We have to redress the bias and discrimination and inequity, not only by responding to interpersonal bias, but also by studying the ways in which bigger social change can happen. Because I truly believe that in 2 years, we will be able to change the oral health system in Maine. And then we have to cultivate and sustain bias-free and discrimination-free communities, which requires an understanding that doing so is a basic responsibility for everyone in a civil society. It's all of our responsibilities. It's not just mine, it's all of our responsibilities. And I need all of my white allies with me so that we can live in a civil society. So I'm gonna stop there. Let me stop sharing and see if there are any questions. I'm sorry I ran through that so quickly.
No, that's all right. Thank you, Regina, so much. That was great to hear the wonderful work you all are doing. So we do have a couple of minutes for questions. So we have some coming in, but if folks have additional ones, please type quickly and press enter so that we can get those asked of Regina. So one of the first questions we have, transportation we hear so often is a barrier for so many folks. Are you all in your work partnering with transportation providers to access oral health care?
It's a great question. And so Maine Access Immigrant Network, they had a oral health program several years ago, and the program ended because of funding. And so our strong partner in this work is Maine Access Immigrant Network, who will reach out to the communities that they're serving. They have community health workers. And so they're the ones that will provide that within the plan.
Great, that's great to hear. Thank you. And one other question I'm seeing right now, you have several statewide partners, but you also mentioned a lot about Portland and Greater Portland. Are there plans to move this work beyond Portland and the Greater Portland area?
Another great question. And so, yeah, so we're doing this in Greater Portland. Cumberland County is looking at it countywide. And then we're also looking at our state providers, because what we're really hoping to do is to come up with a state oral health plan and how they're going to tackle oral health. So we just think that we can do Greater Portland at this point in time, but are really eager and really ready to have the conversations with the state, and are glad that they're partnering with us so that we can look at this on the state level.
Great, thank you. That's wonderful to hear. For folks across the state, I know that oral health care can definitely be a challenge, and as you said, particularly challenging for this community. So thank you for all the work that you're doing. We are at time. Unfortunately, 30 minutes goes quick. I've said this in session so many times. Everybody's topic could be its own conference in and of itself. And I was thinking we should have ended with Katie's, because now we are going to move into the lunch break and an opportunity, hopefully, for everyone to get outside, stretch their legs, have something tasty to eat. The wind's picking up here, but it hasn't started raining yet. So reminders, please take the evaluation. You can find those all in each session's agenda session. If you have trouble navigating them, we'll send them out at the end of the day too. So thank you to everyone. We will be back here at 12:30 for a panel on virtual education and programming. So thank you all so much, and enjoy the break.